of the slides. So if you could move to the next slide, Dr. Luthart.
Yep.
I touched on this a moment ago that, of course, disability following stroke is a major issue in the United States, but also globally. And 3 million Americans suffer with upper extremity impairment. You can go to the next slide. We touched on this a little bit, but one of the unmet needs is that people are just not getting enough repetitions with their arm and hand. Hence, they struggle to use their arm in everyday life. And there is a phenomenon that occurs that's called learned non-use. That occurs because a stroke survivor is often taught compensatory strategies where they'll use their stronger arm to do certain tasks. Unfortunately, their brain is just not able to connect again to the impaired arm. Also, we are finding that stroke survivors don't have access to technology. So there's not a lot available for use in the home. And we know the home is a good place for a lot of stroke survivors because if they have a technology in their home, they can use it to the intensity and the dosage that's needed for that neuroplasticity to take effect. And then point 3, common therapies just don't have a lot of efficacy for motor recovery. So that brings us to the next slide, if you could move forward. And I think I'll just have Dr. Luthart kick it off by showing this. You'll see Dr. Luthart on this video. This is featured on Bloomberg Report. We love showing this video. It does date back a few years, but it does show a nice timeline as to where this all began and kind of paints a picture. So you can push play now.
When we first started this company, people almost kind of took this as just kind of almost crazy science fiction. And I think we're getting past the believability factor. We're starting to see what was originally kind of research technology take flight in the clinical domain. And I think we're going to see many, many more of these type of technologies.
Here in St. Louis, a company called Neurolutions recently got one of the first FDA approvals ever for a BCI. In this case, a non-invasive EEG headset that reads the electrical activity of the brain. The measurements aren't as precise as with an invasive system like the one BrainGate uses, but they work for Neurolutions' purpose, helping stroke victims to reconnect their mind with a paralyzed limb.
All right, so we're just going to test the headset real quick. All connections good, nice and relaxed.
My name is Mark Forrest. I live in St. Louis all my life, and turns out I had a stroke. And I was pretty much paralyzed on my right side. A lot of people told me after 6 months that I was pretty much done and I was going to have hardly any movement.
When somebody has a stroke, a part of their brain dies. For instance, the right side is injured and the left side can't move. Now, but if you talk to these patients, they can imagine moving, they can try to move, they just can't actually execute that movement.
We know that 90% of those motor fibers that control opening and closing that hand are on that side where the injury occurred. What we found is that there's actually 10% on the healthy side, on the other side of the brain, that controls thought of, I want to move my hand.
And so what we did is we created a brain-computer interface that really has 3 parts to it: a wearable headset, a robotic exoskeleton, and a tablet that walks them through how to use the system.
All right, let's see. So let's do 30 seconds rest, and then I'm going to hit next, and we'll see what control you'll get.
At the beginning of the program, it tells you not to move your hand, but think about moving your hand. And that's what you have to do.
Just imagine.
It's picking up that intention to move on the uninjured side of the brain. It's converting that intention to a movement of the exoskeleton. As the person continues to use it over time, it's essentially leading to a rewiring of the brain. There's this kind of neuroscience notion of what fires together, wires together. So when they're generating those brain signals to move and they're getting that feedback from that wearable, that's leading to new connections forming in the brain that allows eventually that uninjured side of the brain to take over control of the paralyzed limb.
My movement was just this. That's all I could do. Look how much difference I've made, progressed using that machine. I have arm movement, I have finger movement. I have wrist movement. It got me motivated to where I actually built my own fishing boat. My oldest son said it's going to sink, it's not going to float. My best friend told me it was going to sink and not going to float. Well, I proved them all wrong. Laura works in mysterious ways. It happens and nothing new about it. So you just make it work.
Cool.
Oops. Well, maybe I'll pick it up from here. And again, my name's Eric Luthart. Again, you just saw a video of me, but again, I'm the founder of Neurolutions, also the inventor of the technology. And just as a day job, in addition to being the chief scientific officer, I'm also vice chancellor at Washington University in St. Louis. I run the division of neurotechnology, and I'm a practicing neurosurgeon. Um, so it's been a passion of mine to create, kind of neurotechnology solutions to help, patients, with whatever neurologic disease improve. And a big one, obviously, is stroke. So again, one of the one of the, really the central technologies that I've really been passionate about is this idea of the IPSI hand. As I mentioned in that video, it's got three parts, right? The EEG headset, the handpiece, and the tablet. And so, again, the goal for this brief presentation is really to do a journal club about kind of the recent paper that we published showing that one of the things, and you heard Mark say it, was that, hey, my hand got better, but my arm, and we generally saw that when we were using this to help patients, and again, the therapy typically involves 12 weeks, even though it's their hand that is being controlled by their unaffected hemisphere, we are seeing a much broader impact. And so the point of this article was to really show that patients' arm generally improves, and that's actually what led when we looked at the data and ultimately submitted to the FDA was for broad upper extremity approval. And again, just to kind of again do some background as far as what these patients experience is that, again, they've got their headset, they've got their tablet, they've got their robotic exoskeleton. They use the system for approximately an hour a day for about 12 weeks. And again, the tablet walks them through to basically imagining opening and closing their hand, and we basically decode those signals from the brain through that tablet so that basically can control the opening and closing their hand as if they were doing it with their intention alone. And so for this study that we did, we wanted to look at, again, a number of different metrics of, functional outcomes, but a number of those metrics, importantly, the Fugl-Meyer assessment also looked at, kind of different aspects of limb movement. And we wanted to see how kind of, those improvements were across a general arm function. Again, just, again, getting to kind of the bottom line is when we look at upper extremity Fugl-Meyer scores, the minimally clinically important difference is considered an improvement of 5.25 for these chronic stroke patients. And again, when we define chronic as being greater than 6 months out from their injury, that we saw an average of 8.1 points of improvement. Importantly, and I'm going to kind of walk you through some of the details of this data, is that they had improvements both in proximal and distal upper extremity function. So they really had broad improvement. And also I want to show you some of the secondary measures that, again, this wasn't just kind of a one-off in terms of, that specific functional assessment, but across a number of other secondary measures, we see improvement. So again, to get to the meat of the story is that, and again, this is going to sound a little funny, but I'm just a neurosurgeon here. You folks are the neurology team, so you're going to know this a lot better than I am in many ways. But again, this is, the upper extremity Fugl-Meyer section scores, and again, they are broken down into different aspects that reflect, again, your reflexes, your proximal upper extremity, the A2, A3, A4, distal upper extremity, the section B, section C, and then coordination. And hopefully what, I can draw your eye to is that across all of these metrics for upper extremity Fugl-Meyer assessments, there's statistically significant improvements across the patients that we studied. And again, I think it was in the previous slide, but this was looking at 26 patients. And again, you see that again over time, when we go from the 4th week to the 8th week to the 12th week, we see improvements again, and it looks pretty consistent across each of these aspects that are different, measuring these different features of upper extremity movement, that it's improving. Now, the one thing is sometimes, especially when we were first kind of rolling this out, a big question was, well, is Botox playing a role here? Do some of these patients have Botox? Did some of them not? And sometimes patients with spasticity, are we just seeing a Botox effect? We expressly looked at that. And again, regardless of whether these patients had Botox or did not have Botox, there was no statistically significant differences in any of these measures based on Botox. Again, to get a little bit more granular here, now we're looking at upper extremity Fugl-Meyer in the upper left here, but we also looked at action research arm test, the AMAT, the motricity index, the gross grasp strength, as well as the modified Ashworth scores. And again, I think the things that I'd like to highlight here is that again, I showed you in granular detail how the upper extremity Fugl-Meyer improved across our group, but also the action research arm test, the AMAT, the motricity index, as well as grasp strength. All these things improved across those 12 weeks. What did not change was the modified Ashworth score. So the patients retained their spasticity, but their function improved. Now, we were talking earlier about this issue of dosage and this issue of usage and effect. And I think one of the things that we identified is that the more patients used their BCI, the better that they did on average. So, and I think this gets at, and again, because it's at the home, because people, can own it and control it and use it on their own, that we really do get a lot of, substantial usage. But again, there's variability across people. And again, here we see, again, consistent with really a lot of physical therapy literature, is that the more they use it, the better that they get. And again, just to highlight some of that is people who really, if you look at that top quartile, if you look at those patients and who really used it, absolutely consistently, they had the best effects. And some of those upper extremity Fugl-Meyer scores were, between 15 and 25. And so some really substantial improvements. And again, this was a linear trend and it was statistically significant. Now, the other thing that I wanted to highlight here is we also looked this both within this study as well as additional studies. We wanted to look at their we've seen how kind of their function changes, but how does their brain itself change? And one of the things we looked at is just the electrophysiology. And again, I'm going to dive a little bit into kind of, some deep physiologic, analytic approaches, but we looked at what's called phase amplitude coupling. Very specifically, how a low frequency signal and how its amplitude modifies a high frequency signal, especially theta gamma coupling, like theta being around 3 to 5 hertz and gamma being high frequency rhythms. The interaction of those two rhythms has been associated with learning and memory and motor learning specifically. And so we wanted to look at this across time for these patients that we treated. And one of the things we found was that theta gamma coupling, basically, again, baseline theta gamma coupling, they're not doing anything when we're measuring this, is changing, is increasing as the patients improve. And again, this statistically and linearly correlated with scores such as the upper extremity Fugl-Meyer and the AMAT score. And in many ways, it actually can almost be a physiologic biomarker of how their brain is changing. And that correlates to how they're functionally improving. Now, in a subcohort of patients, we also looked at functional imaging. And so we wanted to look at, again, essentially basically motor system connectivity from the lesional and the contralesional hemisphere and how they changed, before and after doing IPSY hand therapy. And I think, again, what you're seeing in kind of that right figure A is that's their baseline levels of connectivity, that you can see that there's strong connectivity, again, in kind of, classic areas, nodes in the motor network, M1, premotor, supplemental motor areas, as well as, cerebellar regions. The thing that I would like to, bring your attention to is that connectivity, again, this is baseline functional connectivity when they're not doing anything, it's resting state fMRI, fundamentally changes across the entire network. And basically what you see is that there's a complete reorganization of how the motor networks are talking to each other. So the combination of the functional imaging plus kind of this electrophysiology is telling us that there's with theta gamma coupling and network remodeling that there's a fundamental learning happening and that it is changing brain dynamics. So, um, so again, kind of putting all that information together, back in 2020, this solution was given a breakthrough designation device by the FDA. It is the first FDA cleared BCI device for chronic stroke. I guess technically speaking, I think it's the only FDA approved thought controlled system that's out there just yet. And it went through what's called a de novo class 2 medical device clearance. So I think, key takeaways that I would think about this, and again, I've intentionally kept this somewhat short so that a lot of, kind of this time can be spent answering questions and having a discussion. But the top 3 takeaways that I would hope you take is that, number one, IPSI BCI therapy really does yield clinically significant motor gains in chronic stroke. We see these improvements that we see are both in the proximal and distal upper extremity, and that the more they use it, the better that they do, and so that there really is a dose-response relationship. So again, I think that this is something that where again the patient's motivation and importantly their support structure can really, the more we can get them to use this, the more likely we can get them to have a meaningful recovery of that upper extremity. So again, that was kind of a whirlwind tour, but I would love to take any questions and thoughts about the system and let you know anything we can tell you.
Everyone's digesting it right now.
Thank you, Dr. Liz.
Yeah, I see a question. Dr. Prinsloo?
Hi, thank you so much for this work. It is so exciting. It gives me chills. It's amazing. A couple of technical questions. Did you have to do the phase amplitude coupling to see significant difference under the electrodes, or were you able to see specific bandwidth changes as well, like under C3 or C4?
Yeah, that's a great question. So you can absolutely, so we looked at, amplitude changes. We looked at, kind of, phase changes between electrodes. And the one that you absolutely and certainly do see amplitude changes over time. And actually, as the patients, improve, their control, their ability to distinguish between active and rest becomes better. But the signal that most closely correlated with their functional recovery at baseline was theta gamma coupling.
That's impressive. And then second question, what would you anticipate doing if there was a bilateral issue, if you don't have the normal side to train to? Would normative databases help with that or not?
And let me make sure I understand the question. So if they had like bihemispheric injury?
Yeah.
Yeah, that is a tougher one. I guess the bet now I'm going to kind of venture into anecdotal experience and thoughts. I think fundamentally that this is a tool to enhance brain plasticity and functional recovery. If you have an actionable signal, and again, I think the best one tends to be the non-lesional hemisphere because that's the least marred by the injury of the stroke. That gives you the signal. And what is fundamentally important is that you couple that intent to move with functionally relevant sensory input. That's why the robotic exoskeleton creates this kind of, a Hebbian loop where basically they are getting that critical feedback precisely timed with the intent to move in the physiology that leads to that enhanced connectivity. Now I'm about to venture into kind of anecdotal experiences that can potentially try to answer your question. There's been some patients who have had locked-in syndrome who have used the system. They, technically speaking, have bilateral motor disability that's been substantive, that they really, could barely move at all. And, and it was a younger patient. We were kind of like, well, they technically fall within the parameters of they've had a stroke, they're chronic, and they've got a motor disability, so they were able to use it. Actually, that patient surprisingly had a meaningful amount of hand functional recovery. That, I remember made the mother breaking down into tears, like, after a couple months of using it. So I think that even with bilateral injury, it's feasible, but I'm going to put on my chief scientific officer hat, like of Neurolutions, but that is not indicated. Right? You know what I mean? Like that it is, so, yeah, but I think that, again, if you've got a chronic stroke, you're greater than 6 months, you've got a motor disability, that I think that you're a candidate as long as we can find a kind of an actionable signal. Does that make sense? Does that answer your question?
Yes, perfectly. It's amazing. Thank you so much.
Yep. I see Dr. Sandeep Subramanian.
Yeah, hi. Thank you so much. I guess I'm looking on the wrong screen. I have two screens. I guess I just need to move to the right screen. Uh, uh, Great work. Thank you so much. I was wondering what was your rationale behind looking at people with and without Botox?
Honestly, part of it is just the question came up frequently. And we really wanted to make sure that we controlled for everything to show that the effect is not, secondary to other causes, especially, again, I think especially in the context when you're using chronic stroke patients as their own control, you want to make sure that basically anything that could affect their baseline is being controlled for. So I think that's the primary reason. And the other thing is that we don't want to prohibit patients from participating in the IPSY hand trial or IPSY hand utilization because they're on Botox. So we took all comers and we just we did a sub-analysis and controlled for it.
Yeah.
Okay, thank you. I just
On that real quick is we were very careful. So if somebody did get Botox, they would receive their Botox, and then they would get the IPSY hand system within 7 days. And they had to.
Thanks, Lauren. Yep.
Yeah. So we just made sure that it was consistent throughout their course in the study.
Okay, no, perfect. Thank you. And I had a second question that's more of a fundamental, from the neuroscience part of it. We do know that we've had these lot of things from, where we had the work from Nick Ward and the others in 2004, which said that, one hemisphere completely takes over, the other is down versus not. We've had the 10%. But now we had the more recent work that came out in 15, 16, 17 from Stenier and Biblo and the others, which said that, the affected hemisphere, is it your friend or your foe? If you're very severely affected, then your non-dominant hemisphere is the one that's kind of taking over. If you're less affected, then it's the dominant hemisphere that's taking over. So with your change that you are seeing, that the maps that you showed, where the connectivity changed, the functional connectivity, did you see that in the affected or the non-affected hemisphere? And what is your solution for people who might not maybe be as severely affected or connectivity changes? Do you start seeing more intense signal coming from the dominant hemisphere or the ipsilateral hemisphere?
Those are great questions. So, and I'm going to recap some of it just because I think it's worth emphasizing. One is that it truly is this relationship between the lesional and the non-lesional hemisphere is dynamic. And I think there was this era where people said, oh, the unaffected hemisphere is the bad guy, right? And then they're like, well, wait a minute, no. I think, and I think this gets at, this notion of early on, if the good hemisphere can truly recover function, then great, that wonderful. If it can't, that's when the non-lesional hemisphere plays a larger and larger role in recovery in the chronic phases. In some senses, that's why I think the IPSY hand, because it uses that unaffected hemisphere later in recovery, is kind of, I think that the ideal solution. Now, to get at your this, that's kind of the setting the stage of, when I look at this, functional connectivity and electrophysiology, quite honestly, is that that you do see bihemispheric changes. And I think that you are seeing global brain changes. And again, I'm going to get into the kind of the weeds a little bit here, but the connectivity changes that you see are actually bihemispherically reduced. You see actually reduced connectivity, cross hemispherically. And to me, I think that what that's telling you is that uh, um, you probably had, again, I think it has a lot to do with learned disuse. It has a lot to do with essentially kind of the unaffected hemisphere as it's gaining, functional activation and independence. It is actually becoming less connected with the global motor network system, which in the chronic phase is just fine because we do know in the acute stage, you get an injury, you see reduction in connectivity that recovers with people in the acute stage. But I think in this chronic stage, it's a completely different game in that you've got this learned disuse, this over connectivity that's probably pathologic. The unaffected hemisphere is gaining function and it's becoming more independent from the dysfunctional hemisphere. So that's why I think you see reduced connectivity.
So would you say that in a certain sense, and I'm just, this is great, it's very interesting, so I'm just pushing you a little bit.
Please.
So would you say that this is a form of neural compensation? Because we're seeing behavioral restitution, but I'm going back to, I did my PhD under Mindy Levin, so recovery compensation is like, very famous thing we speak
it's a
about.
great question.
So do you think we're seeing more of neural compensation, but we're getting behavioral restitution? And it may not be a bad thing, but I'm not here to say if it's good or bad. Ultimately, our patients are getting better. That's all we all want. But do you think that could be the mechanism that's driving this?
It's actually just parenthetically, like part of my lab and research, we also have a primate stroke model that we just developed over the last 5 years. How much is true neural remodeling versus how much is adaptation that's leading to imaging changes, right?
Yeah.
I think the answer is probably yes,
Okay.
meaning that I think that I do think that in the setting of injury, that there when especially when the corticospinal tract is affected, you have, I think, a pathologic connectivity that is essentially unlocked with the IPSI hand. That's why you're seeing some of that reduced connectivity over time. Now, whether we want to call that an adaptation or whether a true neural remodeling, I think I would probably lean more towards remodeling because if you're seeing connectivity changes, resting state connectivity is truly, at least to best we understand it, a measure of synaptic homeostasis. And if you were seeing changes in synaptic homeostasis just from a pure, that is neuroremodeling. So to me, I would put it more in the neuroremodeling. But that said, is there a kind of this restitution that is somewhat functional in nature? Perhaps, I probably want to put it more in a grayer zone, but I do think based on the resting state imaging and the fact that I would say that represents synaptic homeostasis, that it is a remodeling phenomenon, and at the very least, and there's probably more to it than that. And that's what we're going to try.
It's just brilliant. This is fantastic to be able to see the kind of connectivity changes you're getting. I think it's just absolutely great. That's why I just said I'm pushing you to the next level because
Please push me. I love it.
It begs those kind of questions to say, really, because what's nice is not only are you showing changes in function, but you're also showing behavioral, like neural behavior, which not a lot of us can tend to do because of various reasons. But I think this is fantastic because it also gives us some keys to the fundamental underpinnings of why we are seeing what you're seeing.
100%. And that's why again, the next stage is really, we've got primate models where we can do the imaging before and after the lesion. We can do electrophysiology before and after. And so stay tuned that we just completed a 5-year primate study. So we're going to have some more clear answers on what these functional imaging changes are relative to the baseline that you see.
Thank you so much.
Yeah. Yeah.
So how did it vary with the lesion size and location, the recovery?
That is a good question. So I'm going to take that in a couple parts. In some senses, I don't think while we've looked at the lesion size, and there has not been a clear lesion volume relationship to recovery. One thing that we also looked at, did it make a difference what your starting upper extremity Fugl-Meyer was to kind of the average benefits that you got. And that also did not seem to have a relationship. And I think, I guess my personal takeaway from this is that in some senses, the things that matter is you have a chronic deficit, and I don't care too much about what the injured hemisphere looks like, as long as we're seeing, actionable signals in the unaffected hemisphere that appears to be able to give you a benefit of, again, on average, around, 8 points in your upper extremity Fugl-Meyer, whether you're starting at a very low Fugl-Meyer or whether you're starting at a moderate or higher Fugl-Meyer, but that's the average. And again, the more you use it, the better you do.
Okay, my one question more is about the connectivity.
Yeah.
Did you compare the patient who were, treated versus non-treated?
Oh, so actually, that's a great question. Our control for that group, actually, and again, it's not in this figure, but I can show it to you, is we looked at, I think it was actually around 40 patients who had intensive physical therapy to see kind of, again, because the other thing is, again, if you're using their patients as their own control, like, there's all these questions of like, what happens if they didn't get therapy? Our control for that particular study using functional imaging, we compared it to 40 patients who had the exact same imaging protocols. And actually, they had none of those connectivity changes that I just showed you. I can pull those images up if you just give me a sec. But basically, patients who underwent pure, kind of highly intensive, as much time with physical therapy as they would have done with the BCI, they had none of those connectivity changes in their motor system.
Thank you.
I have a couple of questions while he's pulling that up. So first question, what I understand, and I know you're going to explain it a little bit more in detail with the demo, but what I understand from the technology is twofold. So we're incorporating some mental imagery as well as the repetitive force use. And we know when we look at the literature, when we look at the research, that we can have comparable results when we have mass repetition or mental imagery in regards to recovery in the Fugl-Meyer. When I was looking through the articles that have been published with the device, there hadn't been any sham dose equivalent controls, right? And in a traditional intervention or something like that. So is that something that you guys have planned in the future, just to be able to just justify this is exactly coming from this? It's not just the repetition. It's not just the mental imagery.
Yeah.
That actually, yeah, I can. In our first paper, again, we show you repetition makes a difference. But in our first manuscript, we compared repetition versus the quality of BCI control. The strongest relationship actually is the degree to which you achieve brain control. So for instance, if you get more brain-derived control, like meaning that as you're opening and closing the hand, you do it more correctly on the cues, those patients have a better functional recovery than those people who had poor BCI control but just used it frequently. And also, and maybe also just to highlight to get at the, like, we are currently in the midst of a randomized controlled trial where patients are either getting physical therapy or are getting IPSI hand BCI therapy.
So yeah. Are they getting physical therapy or are they getting occupational therapy?
Oh, fair. Say PT, I don't say it's OT. No, so if they're getting a home exercise program, so when they come in, we wanted to compare it to what does a chronic stroke patient have traditionally.
Sure.
Traditionally, they don't have anything, but we give them a home exercise program that they're supposed to do just like, 5 days a week, 12 weeks. So, and then preliminary, and again, everything's preliminary, and we're hoping to wrap this up by the end of the year. Control right now is showing about a 0.8, which is actually consistent in the literature of all other interventions as well. So things are trending actually just as we would expect from our literature and then other BCI literature that's doing the same work.
And the exercises, they're dose equivalent. Are they similar to what is being done with the device?
Yes and no. I would say yes in the fact that we are looking at the hand and range of motion and looking at their level of degree. But they are also doing proximal and whatnot. Now, this is, obviously it's doing this. Sure.
And then, sorry,
He's going to do, I think, some slides real quick.
Sure. Last question from me, I think. How long are the follow-ups? Are you seeing these improvements being sustained?
We are. Oh, good. Yeah. So,
Great question.
Yeah, with durability, we've looked at that. We brought them back 6 months post no use of the device. And what we've seen is maybe like a shift of 1.1, plus or minus 1. So everybody has actually held their gains at 6 months and 1 year. And then, and I don't know if you were talking about durability follow-ups, but just follow-ups of when we begin to see like a trend of improvement. Usually we see it around the 6 to 8 week mark. And then what we are seeing more in the commercial data, which we are going to publish a paper on this pretty soon. What we are seeing is actually we're tracking them beyond the 12 weeks, and we're seeing even better improvement beyond the 12 weeks. Do you have those slides, Eric, or we?
I'm looking for, I'm sorry,
We can do a
stay
demo
with
right
me,
now.
I will
That's
get
okay,
there.
we can do
Yeah.
a quick little demo while you're looking.
Yeah.
So I'm just gonna move toward the camera so everyone can sort of get a close-up view of what the handpiece looks like. This is a handpiece that is for the right hand and forearm. This is going to be placed on my hand when I'm actually going to be doing the therapy. But just for demonstration purposes, I want everyone to be able to see that through just my thought control alone, I can operate the motor within this handpiece. And then I'll put it on so you can actually see the fit, and then a lot of questions will come out, I'm sure, about, what's happening? Why did we design it as such? But one of the things I want to mention is that when someone's doing the therapy, we want them to be in a very relaxed, calm state of mind, right? It's important that they're not standing, that they're not doing a ton of dual tasking, as much as my OT brain loves dual tasking for certain things. Yes, yeah. In this context, we actually want them to be relaxed and focused so we can really target the specific areas of the motor cortex we're going after, right? So we do train, or I should say instruct our individuals every time they get a system that they have to do this in an environment that's quiet in their home, sitting down. They are going to be spending about 60 minutes of time doing their therapy. You can break it up into, 2 30-minute sessions if the person doesn't have the attention and focus right off the bat. But the protocol in terms of clinical applications is 5 times a week for 60 minutes. And although our clinical papers do talk about how we had folks do it for 3 months, in the real world, we want them to continue using it as long as they're seeing an effect, a positive effect. And our team at Neurolutions actually does support the delivery, the training, and then ongoing clinical and technical support as they continue to
So we
use
do
the
have
device.
OTs that are doing fecal Myers with them basically every 30 days, just so that we can understand what's happening in the real world too.
So I'm not sure how well people can see this, but I'm just going to rest this the best I can. The thumb is stationary. So when it's worn, we would position the thumb into a C curve. And then the dynamic piece of the device is going to be moving the index and the middle finger up into extension and then lower it into flexion. So I'm going to be following along on the tablet. I know it's difficult for those in the room to see what's going on, but actually maybe what I could do is just scooch here.
If you want to talk while she's getting ready, you can go
Pretty
through this
much
real quick.
ready. And Lauren, one thing I wanted to mention is because I don't want artifacts of me talking or, doing a ton of hand motion, I'm going to try to quiet my mind for a moment. And then Lauren can actually
I can answer
speak
questions.
to what's happening.
Yeah.
Okay, I'm going to relax.
Right now she's having a cue that's telling her to rest and calm her thoughts, which is probably the hardest thing to do, is to like not think about anything. So now, right now, she's thinking about moving her hand, each finger posing to her thumb. It's probably gonna take a few cues to get through since you're moving. So a big thing that we notice is that if anybody does a lot of movement, we kick off the EMG signals, which can then make everything a little bit noisy. So that's why, again, it's really important just to kind of be very nice and relaxed.
Have you guys encountered any issues with different hairstyles or hair
Oh,
types?
yes, we definitely have. Typically, we have some tips and tricks to make things work. We also know that if somebody has really thick hair or thick braided hair, we really need to move that out of the way so that there's at least a good contact from the sensor to the scalp.
Sure.
So. No wigs, we've had that. Somebody did a screening one time, not realizing that they had a wig on. Obviously, we can't get a good signal acquisition with that. So. Next cue. Our next cue should be trying to think about moving her hand. And as she does that, the device will open up and give them that feedback in real time. And if you see it kind of moving and bouncing up and down, I call it being chatty. It's really responding like right in time to the thought. So, I mean, it's pretty precise. If you're not paying attention, it's not going to work. So if I were to put this on, I would not have good control, especially right now. I fluctuate, it depends. So typically, a lot of questions we get when people see this is, can you gamify it? Can you do something fun? And kind of, you know, what I think of it as an OT is that really you're wanting to keep the brain quiet and focusing just on this area to strengthen. So I really don't want all the bells and whistles and all that stimulation happening in other areas of the brain. I want them to focus about the intention of their movement.
So I just have it paused right now so I can put it on and you can see it dynamically move.
I'm gonna let him talk real quick.
Oh, sure.
All right, Eric, you're good.
Yeah, some folks had questions about kind of the altered brain networks, and this was just to kind of dive a little bit. Again, we looked at a cohort of patients. I think it was 10 patients who did IPSY hand, and again, we looked at their pre and their post, and again, the anatomic distribution of activations didn't change so much, but again, I showed you that kind of brief summary where basically we saw, if you look at A and C, that left side. Again, pre-therapy connectivity versus the connectivity you see afterwards. If you look at B and D, what you're seeing is these are kind of, I think it was around 40 patients who had just intensive physical therapy. That's their network connectivity organization, kind of very similar to the pre-connectivity of the BCI patients. But after, you know, kind of same duration of intensive physical therapy, you don't see the same level of network changes at all that you saw in the BCI patients. And also importantly, when we looked at the degree to which we saw changes in that correlation, that also linearly correlated and was statistically significantly associated with the improvement of their upper extremity Fugl-Meyer. So those changes that we see are correlated with their level of recovery. So anyway, that was just to answer some of the folks' questions, you know, around the, you know, hey, did you look at physical therapy or, you know, a matched cohort? That, I think that's the closest we've come so far, but we will have more clear answers in that randomized control trial.
And I was just gonna do a little preface because I don't think we touched on it too much, but any of our patients who use this device, they do go under an EEG screening, which we do with this device. They have the headset, the tablet only, because we do need to make sure that they have a signal. If they don't have a signal, they can't use the device. So everybody who has a device does have a signal, and we screen for that ahead of time.
How often are you finding people are not?
In the real world, it's about 10% right now. In older literature, I would say maybe like 8-10 years ago when they looked at a healthy population, and Eric, correct me if I'm wrong, but I think it was more towards like 18 to 20%.
That's right.
Signal. So in our studies, we were right around 15.
One of the reasons why they might not have a signal is because they just don't have the awareness to understand this is what I'm supposed to be doing. There's a lot of motor imagery, mental imagery being provided on a tablet for the individual. So if they have severe cognitive impairments, not a great candidate. So I can continue with this. And so now that I've got it on my hand, folks, especially in the room, can see what's going on. I'm sorry if you can't see it that well remotely. Are you in thought mode? I'm in thought mode. I did not do well on that one. So I'm supposed to be resting. Second.
So typically if somebody's gonna do a 60-minute session, and not everybody can do a 60-minute session right off the bat, they have to work up to it. But they do have breaks. So it'll go through like a 25, 50, 75, you know, little chunks that they can do, which seems to help quite a bit too. Typically if they stayed at the time, the pace, all 60 minutes through, they get about 150 repetitions that are all, you know, intention based. So not just CPM or, you know, that type of movement, but a very intention focused movement. If I put my OT hat on, the reason I love this actually, and I like it, is because a lot of the facilitatory techniques that we use in clinic, you know, putting on E-stem and having anything that you were trying to do, they didn't have to think about it. And so at least with this, they were putting that intention and firing what they need to get that movement. So
When you guys are doing the Fuglemeier, are you tracking the sensory section as well, or just motor?
Just more, yeah, just the A through D.
I'd be interested in whether or not there's any change in proprioceptive info.
Oh, yeah. So, again, taking off not the FDA labeling hat, but very preliminary and just scientific based. We've had anecdotally a lot of folks have talked about other improvements, whether it was from balance, attention, speech fluency. Enough for us to perk our ears up a bit. So in this randomized controlled trial that's active right now, obviously we're looking at motor outcomes. We're actually looking at lower extremity outcomes of, cognition, attention, depression, and speech. And so we'll see what that shows to see if we capture anything and then just evaluate it at that time.
Put this on pause just for a second.
Any other last questions? I want to be sensitive to time. I know we have about 4 minutes.
I had heard maybe Kristen Gilliam's
Oh, yeah.
been working on this a little bit with teenagers. Is that right?
Yeah.
She told me.
Yeah, I think Luther may have worked with her a little bit. Gillums? Dr. Gillum?
Yeah. No, that she, unsurprisingly, youthful patients with stroke have phenomenal plasticity, and there's one patient that we worked with who literally had a stroke, around 9-10 years old, and it was severe, had a pretty substantial motor impairment, and has been through every possible, has a very motivated parents, have been through every possible rehab regime, and she did this, and she gained really. So Lauren, do you remember? She had substantial
Yeah. I actually, we have a video I can share with you later.
Yeah.
Of her.
But I think pediatric stroke is, again, we are not indicated for that right now. But that's one where I ultimately want to do I'm dying to do a study, because I think kids will do really great.
I think that's a great idea. Kristen and I talk a lot. So I'm Stuart Fraser. I'm a pediatric neurologist here. But I see adult stroke patients too. And so you guys give me a call when you're ready.
Yeah.
I was going to say,
Okay, great.
Stuart runs our pediatric stroke recovery program here, so he'd be a great person for you all to work with.
Great. Yeah.
For the therapy, oh, go ahead.
No question.
I was just going to mention for the therapists in the room looking at this and thinking, well, what's functional about it? It's not functional. This is not an orthosis that you're going to do tasks with. This is not an assistive device. This is a therapeutic. It's going to leverage neuroplasticity, and we think it could complement the awesome therapy that's already being done in the clinic. A patient's still going to need strengthening. If they've got a sublux, this is not going to fix their subluxation. No, not at all. But it could absolutely help boost their motor recovery. And so the two together, that's like the 1-2 punch win.
Mm-hmm. Any other questions?
I was just thinking about the fact that, so this is home based, but so I assume that in this 26 patient study, these patients were not getting any other therapy.
Yeah, they were not.
Correct.
They couldn't be in any active therapy.
Okay, so that was a stipulation.
Mhm. Yeah, it was they would be excluded.
And so the amount of therapy or what the activities that they were engaging in is reflected in that graph on usage.
Mhm. Yes. So we
so
track usage. So every device, HIPAA compliant, but it will send up the usage data. So we can always look and say how many repetitions they have, how accurate were they, how many times did they use it. So if we need to give them a nudge or, anything or see if something's going on, we can do that as well.
So what I'm trying to understand is, so based on the impairments that they have, whether that's the severity as well as the kind of impairments they have, how does that process start? So if a patient is advised to use the device, is a therapist involved in the initial evaluation of which areas that they're going to try to have functional gain on? Or and if that is the case, how is that monitored over time?
So typically right now, we're growing kind of what we can do, because we can't, practice medicine or anything like that as a device company per se. But all of our clinical staff are OTs. And so we're the ones doing the screenings with them. We're the ones training them. We're the ones doing the Fuglemeier. And so, of course, we help guide them in the right direction. We also try to say things like, when you're doing this every single, 5 days a week, we also want to make sure you're trying to use that side and use that arm as much as possible in daily function. So here's a lot of ideas, that you can do to start implementing that. So we strongly encourage that. But hopefully here, pretty soon, we did just have a merger with another company, that we are, if, somebody is not able to get to an OT clinic or a neuro-based clinic or anything like that, that we will have OTs that will be able to follow up with them, remotely and provide that clinical service.
So up to this point, every patient that's undergone, I mean, it's been in the context of a trial, but now I see it's insurance-based, which tells me you're gonna move into a new stage of.
We are.
Yeah.
Yeah.
So
We
now
had-
thinking, how are you integrating with existing practice and rehabilitation
yeah.
therapies?
We did a limited launch in 2022, 2023. We had early adopters using it. 2024, we hit a couple major milestones. This became a HCPCS approved device. There was not a device like this that existed prior, so we had to identify it as something completely unique. So we now have a HCPCS code that commercial insurance payers will potentially cover this, assuming that they have medical notes to back up the need. So we have a team that takes care of that for every patient. So if a physician identifies, I think this may benefit them, all they have to do to get started is send them our way. We'll do a consultation, and then we collect insurance cards and all that. And then we work with the provider. We work with the insurance company. Also in 2024, we had a CMSB determination established for us. And so we're doing a small pilot right now of our first 20 Medicare patients that we're actually sending through Medicare. It's a rental through Medicare. And we're starting with the first 20 just to make sure that we don't see, or I guess, encounter any hurdles that we didn't expect. But it won't be long from now where we will be able to take straight Medicaid for the majority
I
of
think
people.
I mentioned, with you just earlier that as an OT, I think having the ability for them to rent is just amazing, because most of the time I see patients, they want devices, they want technology, they can't afford it. And this kind of allows that pathway to have access and intensity when they need it, but then also to return it when you're not. So, yeah.
What percentage of approvals are you guys seeing if the prescription is there for them to actually have their own device?
I don't know the
that.
percentage, but I think when we just started last June pushing through commercial insurance, I think we've already had a couple hundred that have been approved.
Yeah.
Yeah.
It's been, maybe I can comment a little bit there. It's been much better than expected. We certainly modeled out anticipated percentages, but actually insurers, the private insurers have been much more supportive than our initial expectations. So it's been pretty good.
In the clinical trial you're currently doing, where is it taking place? Who's running it?
Yeah, so that was an NIH grant. So it's primarily out of WashU in St. Louis. It's an 80 patient RCT, 40 and 40. And so right now, I think we're probably nearing 2/3 of our enrollment. We're hoping to wrap up by the end of the year.
It's operating out of WashU.
Yep.
All
Yep.
other sites besides WashU.
We have one other site. It's actually the Neuro Hub down in Orlando. If people are familiar with that, it's a neuro-based only clinic. So yeah, she's running a small pilot around there too.
So in terms of the PI, Alex.
Oh, yes. Yeah, Alex is a PI on that. Eric is actually a co-PI also on this,
Yep.
on the RCT as well.
Catherine involved in any of this?
Catherine Lang.
Yeah.
She's not a PI, but we talk often. So.
She was actually an author on some of the earlier papers. I love Catherine. She's no nonsense and calls it like she sees it.
I agree with that.
So actually, on one of the slides, when we talk about the unmet need and the dosing and the repetitions, it was from the research that she had done actually when I was at the Rehab Institute, where she was basically observing how many repetitions for the upper extremity is a stroke patient actually getting when they come to therapy. And I think it was only about
23.
23 reps in that session. So yeah, not very good, pretty low.
Yeah, I mean, that work in my mind was really landmark. You know, it really was very impactful.
Yeah.
And just how woefully low, you know, the repetitions are in any given session. So
Yeah.
we love any approaches that are substantially increasing.
Right. So, well, thank you, everybody. This has been great. I think, right, we only have till
1, is that right?
Yeah, and we'll stick around for questions.
Yeah, we'll be here.
We'll be here.
Thank you, Eric.
Thank you, everyone. Take care. Bye now.